This video is to help in teaching professionals about kidney biopsy, both native and transplant. It's not designed to teach some basic skills such as hand washing, sterile technique, drawing up anaesthetic, or detailed point of care use of ultrasound. And neither does it discuss the indications or complications of kidney biopsy. It's important to follow a robust referral pathway to avoid excess risk of bleeding, which is the main complication of kidney biopsy. This includes checks on blood pressure control, anticoagulants, blood results, including platelet count and clotting, and social circumstances. For instance, is the patient able to have someone at home with them the night of a day case biopsy? Informed consent must be gained prior to the day of admission, and in this case, the patient information leaflet from UK Kidney Association gives nationally agreed information about the indications, risks and benefits of kidney biopsy. The basic equipment checklist and the instruments are visible on screen. 1% lignocaine, and the operator needs to be aware of the dose calculation, which is 3 milligrams per kilogram. In a 70 kilogram patient, this is 210 milligrams. As 1 mil of lignocaine is 10 milligrams, the maximum dose is generally around 20 mils. This should be more than enough for a kidney biopsy. The other basic instrumentation would be a needle to draw up the lignocaine, 21 gauge green needle, 25 gauge orange needle, 10 ml syringe, a sterile ultrasound jelly and ultrasound probe cover, chloroprep, chlorhexidine and isopropyl alcohol, 11 scalpel blade, and otherwise just basic drapes and dressings. Operator needs to be aware of the basics of point of care testing. The curvilinear probe, which is the abdominal probe, should be used. This will give a greater depth than the linear probe used for vascular access, but doesn't give so much detail. It's important to know how to change the depth and where the depth is indicated on screen. The gain, which effectively is amplification, but risks actually distorting the picture if used excessively. How to freeze the picture and use the simple measurement tool in order to check the depth and length of the kidney. All invasive procedures should have a governance structure. In this case, the local LOCSIPs is visible, and this shows the patient preparation steps beforehand, including checking identity, blood tests, anticoagulants, allergies. Then that the procedure is undertaken in the correct manner with sterility and the appropriate equipment, and that thereafter the patient is handed over correctly to the receiving team, that the event is documented, and that any complications are noted and any equipment issues rectified before the next patient.
Ensure the probe is aligned with the long axis of the kidney. By making the kidney the largest object on screen, this gives the operator the best chance of getting an accurate and adequate sample from the lower pole. Aligning the needle along the plane of the ultrasound beam places it in the correct position. Holding the ultrasound probe vertically upwards reduces the variables of trying to place the needle in the correct plane. The operator should look down over the probe to ensure that the needle, ultrasound probe and beam are all aligned in the same vertical plane.
This is a native kidney biopsy with the patient placed prone with a cushion under their lower abdomen to reduce the lumbar lordosis, making it easier to visualise the kidney. As the left kidney is usually the target, the right kidney has been examined first. For basic size being measured here, ruling out hydronephrosis or excessive cysts or other masses. Once that's been confirmed with the right kidney, then the left kidney, likely to be the target, is examined in the same way. Noticing that the ultrasound probe is held vertically upwards and the kidney is along the long axis of the probe, making the kidney the longest possible length, which is then measured. The biopsy is of the lower pole, and the needle will be approaching around 45 degrees. So once the probe is in the correct position along the long axis of the kidney, the skin can be marked with a blunt instrument to indicate the point of local anaesthetic once sterilised. You're seeing just in the top corner of the screen a slight indentation. This is not to break the skin, but just as a marker. The ultrasound's being set to the correct depth for the biopsy. Excess ultrasound jelly removed before process is started with sterile field. Operator's got sterile gloves on and it's cleaning with ChloraPrep, which is 2% chlorhexidine and 70% isopropyl alcohol. And this needs to have dried before is effective in sterilising the skin. It's done in a crosshatch manner, reasonably robust pressure. Whilst drying, there's a chance to draw up the anaesthetic, and then a sterile sheet fenestrated with a hole in is placed over the site. The skin markings at the lower end of this, allowing the ultrasound probe to be in the field. Sterile sheaths cover the ultrasound probe with some jelly between probe and sheath, and then sterile jelly used in the sterile field. Once again, the kidney's located, held under the long axis of the ultrasound probe, confirmed the site of injection, and then lignocaine 1% injected, initially with a 25 gauge orange needle, intradermal and then subcut, and then a 21 gauge green needle into the deeper tissues. And at this stage, it should be done under ultrasound guidance to ensure it's in the same plane as the kidney and the biopsy. Just evident in the top right-hand corner of the ultrasound, blush of changing white and then black, where local anaesthetic's been infiltrated into the soft tissues. Skin incision with a number 11 scalpel blade, 2 to 3 millimeters, big enough to ensure the needle is not tethered, not excessive. The biopsy needle's been loaded and is available to fire. It's now following in the plane of the ultrasound probe. The operator's looking over to ensure they remain in the same plane, not just concentrating on the screen. You can now see that the kidney's being touched by the needle, which is then withdrawn before there's any movement. Patients has to hold the breath, breathe in, breathe out, and then the needle is fired and withdrawn before breathing starts again. Samples then taken and examined for histology under a dissecting microscope. A second pass is now taken, so ultrasound jelly to form a good acoustic seal. The probe's held vertically upwards and the needle follows it in the same plane to ensure it's along the long axis of the kidney. Operators leaning forward to ensure that it's on the same plane. It can be seen on the right hand screen down to the kidney, touching the kidney and then firing within the kidney. Pressure, expiration, and then removed before respiratory movement starts again. A check ultrasound after adequate tissue's been gained to ensure there's no obvious hematoma, possible a small change at the lower pole of the kidney. It's quite often seen, but it's worth noting. Histology have asked for a further core. Once again, acoustic seal, ultrasound probe held directly above the kidney, pointing vertically upwards, and the needle being inserted. It's actually being held on the needle rather than the holder to make it easier to push through the muscle layers. see the kidney being just touched by the needle and moving backwards. And then needle's pulled back until they're ready for biopsy. Operators now feels it's in the correct position, holds the needle by the trigger, expiration, down to the kidney, fire, and then removed. Sample then examined for histology. The light microscopy will at least show glomeruli or the relative amount of cortex and medulla. It is in no way diagnostic. Native kidney biopsy, patients prone, a cushion under the lower abdomen to reduce lumbar lordosis. The initial scans of the right kidney, you can see that the probe's being held vertically upwards and positioned at an angle along the long axis of the kidney. Makes the kidney look the longest on the ultrasound screen, which then can be measured, which should fit with the departmental ultrasound. Right first because it's rarely biopsied compared to the left, and again, you can see the left kidney with a shadow above the middle pole, and that's a rib shadow. Its longest distance is now measured, which should be, again, in comparison to departmental ultrasound. The operator can now concentrate on the lower pole, which is now being placed approximately mid-screen, slightly to the right of the midline of the ultrasound image on the right. Holding the probe vertically up and down, the skins can be marked with a blunt instrument in order to make a small skin marking to indicate where the local anaesthetic will be going in a few minutes' time. Confirming the position, the skin can then be cleaned of the jelly before sterile cleaning, and the probe set at the correct depth. The assistant will put some jelly on the probe in order to help when it's covered with a sterile sheet. Chloroprep, chlorhexidine and isopropyl alcohol in a crosshatch fashion beyond the small area required for the biopsy. This should be allowed to dry before it's regarded as functioning as an antiseptic. Sterile drape placed over the area with the marking at the lower end, allowing the probe to be in the sterile field, and the biopsy taken along the long axis of the kidney. Probe's now covered with a sterile sheath and confirming that the original skin marking is the same place. If the patient's moved slightly, it may be a slightly different spot. The infiltration of 1% of lignocaine local anaesthetic, 25 gauge orange needle, superficially subcut and intradermal. And then after this, green needle, 25 gauge, along the track of the future biopsy needle under ultrasound guidance, ensuring that the needle's placed under the skin before the probe's placed close by in case it punctures the sheath. On the right-hand side, the small needle's not evident, but some of the disruption from injecting anaesthetic with drawing back to ensure not in a vessel, and then infiltrating along the future track. Lower pole of the kidney is fairly obvious there with a muscle above it. Checking that the anaesthetic confirms with the correct positioning, number 11 scalpel blade, 2 to 3 millimeter incision to ensure that the needle doesn't tether the skin as it's pushed deeper down. The device is now loaded. It's ready to fire with a single thumb pressure. following the angle of this probe. Operator looking over to make sure this is in the same plane. Noticing kidneys dipping with inspiration, expiration, kidney holding breath, and the needle's fired and gains the sample and removed before the patient takes a breath. This is a subsequent pass. For a second visible previous pass, a little white line that's disrupted the tissue. Needle's now dabbing on the lower pole of the kidney and removed back 0.5 centimetre. Inspiration, full expiration and breath hold. The needle fires and it's evident within the depth of the kidney and then removed before breathing. This is a post-biopsy scan to check there's no obvious hematoma or abnormality formed. Generally, would not require a stitch, but a dry dressing. A native kidney biopsy, the patient's prone with a pillow under the lower abdomen to reduce lumbar lordosis. Likely to be a left-sided biopsy, so initially the right kidney being located, measured along its long axis, and then the screen frozen and measured, checking that there's no hydronephrosis or excess cysts, or that the kidney is of a small size. There's a rib shadow over the middle of it, but the kidney's there in long axis with a good view and easily measurable. And this should largely be in keeping with the departmental ultrasound required before a biopsy. Moving to the left kidney, again locating the longest axis, making the kidney as long as possible, marking the skin with a blunt, in this case wooden stick, after measuring the longest length of the kidney. The operator's fingers there is locating the point of local anaesthetic and entry for the needle at a later point. Noticeable that the probe's vertically upright and being swept along the skin rather than angled to ensure that the operator can stay in that vertical plane with the probe and the needle at all times. Skin marking where the anaesthetic's going to be placed, and you can see the lights changing as the lights go up after the scanning's finished. Once again, long axis of the kidney, making sure that the probe is in a vertical plane. The lower pole is the part of interest, but the whole lower part of the kidney should be visible to ensure the needle does not reach any other structures. Operator's now happy that the marking's correct position. The jelly's removed. Probe can be covered with some further gel to ensure a good seal with the sterile sheath. Operator will scrub up, put on sterile gloves, sort out their sterile field and instruments, and then start cleaning with ChloraPrep, chlorhexidine and isopropyl alcohol. It's done in a crosshatch manner with some pressure on the skin to ensure it's adequately placed. This should be allowed to dry before any intervention. Sterile fenestrated drape with the mark point at the lower end. Once this is in place, there's a ultrasound probe can be covered with a sterile sheath and placed on that field. Now, checking that the patient hasn't moved and that the marker is correct. Then local anaesthetic insertion, warn the patient, and then intradermal and subcut with the 25 gauge orange needle of 1% lignocaine, total volume around 10 mils. After that very superficial injection, everything else should be in the plane of the biopsy. There's then a 21 gauge green needle inserted into the skin before the ultrasound probe's placed close by to avoid puncturing the sheath. And then the operator was leaning over to check that they're in the same plane. Everything now remains in that same plane as the ultrasound probe. And a small amount of disruption to the picture visible in the top right-hand corner. The needle can be tested whilst the lignocaine is given a chance to work, and then an 11 gauge scalpel 2 to 3 millimeter incision and the 16 gauge biopsy needle inserted into the skin, ultrasound probe then picked up and placed in the correct position. And after this, everything should be along the plane of the ultrasound probe. So looking over, the left hand, the ultrasound probe, the right hand and the needle should all remain in the same plane. Here, the tip of the needle can be seen just indenting at the top of the lower pole of the kidney, withdrawn back to train to get breath holding, inspiration, full expiration and hold down to the kidney, needles fired and removed before breathing starts again. The sample is examined by histology. We need at least 2 decent cores. I would suggest a maximum of 3 cores within the kidney. Needle being held just to help accuracy in pushing through the muscle planes. Just touching the kidney there, withdrawn back to avoid damage to the capsule. Then instructions to the patient, inspiration and then expiration. Breathing in, out and hold. Needle down to the kidney and fires. Then withdrawn before breathing restarts. Brief ultrasound to ensure no hematoma, and you can actually see the line of one of the passes as a white diagonal in the right hand corner of the screen. If the laboratory scientist requires further sample to make a diagnostic biopsy, a further pass again enters the skin before picking up the probe, and then the needle held to help pushing through the tougher muscle planes, keeping it in the plane of the ultrasound probe. Be seen down and it now just touching the upper capsule of the kidney, withdrawn slightly to sort out breath holding. Breathing in, full expiration, down to the kidney, fired and then removed. The cores under the light dissecting microscope to ensure that glomeruli are visible and that the yield is likely to be adequate to make a diagnosis, and that the sample can be then subdivided for light microscopy, immune staining and electron microscopy. Kidney transplant biopsy. Patients lying supine with a pillow, trying to keep them comfortable. Obvious scar in the right iliac fossa, and the ultrasound probe being placed along the long axis of the kidney, which is visible in the top part. But also, in this case, it's visible a large dark area, which is urinary bladder. As the kidney spends longer in the recipient, they may effectively sink down into the abdomen, and the upper pole can be covered with bowel loops, although extraperitoneal. In this case, the lower pole is more easily reachable. Kidneys can be measured. Entire kidney on one screen. Caliper points at the upper and then lower pole. And now concentrating on the lower pole, the scale on the right-hand side of the screen being centimetres, so the tip of the kidney is a maximum of 2 centimetres from the skin. Operators marking where the local anaesthetic is going to go with a blunt wooden stick, avoiding the surgical scar, which will be difficult to push through with the biopsy needle. Abdomen's then cleaned for jelly before a sterile process begun. Remember that in this position, the patient can see the whole process of the biopsy. Important to be, as well as maintaining dignity, ensuring that needles aren't waved at the patient, and it may be worth including the drawing up of anaesthetic with the operator and body in between the patient and the assistant. After skin cleaning with chlorhexidine, the area is draped to give the long axis of the kidney and then the biopsy point. The operators checked that the probe's the right way around by placing a finger underneath whilst looking at the screen, as it's very easy to switch the probe around 180 degrees. Agreed entrance point, local anaesthetic, so subcutaneous and intradermal, using a 25 gauge orange needle, 1% lignocaine. In transplant biopsies, rarely needing more than 2 or 3 mils because of the superficial nature of the kidney. There may also be some residual paresthesia after nerve cutting during the incision. Here, the 21 gauge green needle can be seen down to the capsule, leaving a puddle of anaesthetic in that perinephric region, and then injecting more as it's withdrawn. Testing the biopsy needle while the anaesthetic works, and then a small incision with a size 11 scalpel blade, 2 to 3 millimetres, to allow entry of the needle but without tethering of the skin. Ultrasound probes on the long axis of the kidney, and the operator's looking over to check that the needle remains in the long axis. See it's now pressing down on the lower pole of the kidney. Patient's warned and a sample taken. Transplant kidney does not move with respiration, so there's no need for breath holding. Second pass, needle tip under the skin before picking up the ultrasound probe, aligning the probe along the long axis of the kidney and then aligning the needle with the probe. Needle here down to, and taking a transverse section to ensure that the best yield of cortex is available. Needle down onto the renal capsule, arms braced as the capsule may be quite tough to penetrate and there's a chance of the needle bouncing back. Pass going into the kidney, manual pressure on the site, and the sample examined under light microscopy. ultrasound scan to ensure that there's no obvious hematoma. Kidney transplant biopsy. The transplant's in the right iliac fossa. Here the probe is along the long axis of the kidney, allowing measurement of its full length. Evident that the collecting systems are quite prominent, which is common in transplant. It does not infer an obstruction and hydronephrotic picture. Picture's frozen to allow measurement. Some estimation as the kidney does not fit on a single screen because of its proximity to the probe. The upper pole of the kidney is quite close to bowel, which can be seen with peristalsis. Therefore, the decision here is to go for the lower pole. This is quite close to the urinary bladder, which is visible on the right-hand side of the screen. And it may also be possible to see the large vessels, iliac artery. The lower pole of the kidney now just to the right of mid-screen on the ultrasound probe, and a mark made to indicate where the local anaesthetic is going to be applied. The angle of approach is going to be quite steep here because the kidney is very superficial. The scale on the right shows that it's only 2 centimetres from skin to lower pole. Lights up after stopping using the ultrasound. Marker with a blunt wooden stick, and then just repeat ultrasound to ensure that's the correct positioning. The probe can now be covered with some further gel. Operator washes their hands and sorts out the sterile field to be able to commence the biopsy. Prominent iliac vessel visible just below the kidney on the right. Probe's being swept across the kidney rather than angled to give the operator some form of three-dimensional representation where the largest, thickest area of renal cortex is to optimise the yield of glomeruli. Cleaning off the gel before the cleaning process and skin sterilisation. The kidney is obviously close to the groin, and there's going to be a balance of getting optimal skin cleaning whilst maintaining patient dignity. In this case, using some sterile paper in the corner of the field. Sterile fenestrated drape with the whole lower aspect where the skin marking is, so that the long axis of the ultrasound probe can be held in the rest of the area. Sterile ultrasound jelly. Kidney identified. This should correspond with the initial marking, but if it's a different spot, then use the more accurate new one. Orange needle to give subcut and intradermal anaesthetic. Maximum of 10 mils of 1% should be adequate in this case. After the initial very superficial local anaesthetic, all the rest of the injections and needles are done with the ultrasound along the long axis, heading down to the kidney. In this case, even an orange needle is almost down to the renal capsule. Now, 21 gauge needle with 1% lignocaine along the plane of the ultrasound probe down to the renal capsule, around 2 centimetres, and then anaesthetic injected as the needle's withdrawn. Number 11 scalpel, making a small incision to allow the needle to pass without tethering the skin. .16 gauge needle is now loaded and ready to fire. Kidney's long axis identified and the probe held along this. Operator leaning over to ensure in the same direction. The needle's on the renal capsule and then fires, and it's visible disruption of tissue in the renal capsule. Patient reported that it was shock but not pain, just surprised by the noise of the spring-loaded instrument. Second pass, the probe's held along the long axis of the kidney, making the kidney look as long as possible. Needles being pushed down through the tissue, which may be scarred after the operation and require some pressure. In this case, holding the needle to avoid it's not pushed too far accidentally. Then the needle's against the kidney capsule, patient warned. So the needle's withdrawn, and then a check ultrasound scan. See the blood is visible on the right, no obvious hematoma, whilst the laboratory team are checking the adequacy of the sample. Further cause required. Needles inserted before the probe and the probe cover are close by to avoid damaging the cover. Pressure to get down through the scarred tissue around the kidney transplant. And again, it's quite a lot of pressure to get down through that scarred area, avoiding bladder to the right, getting the tip of the needle down onto the renal capsule. And then moved on to the trigger point of the biopsy needle. Patient warned and sample taken, in this case quite visible in the renal cortex. Ultrasound of the kidney, just sweeping over, checking the locality for any hematoma. Laboratory scientists checking the samples under dissecting light microscope. Noticeable that kidney transplant biopsies can be quite a pale sample.